Peace and light to you all, and many thanks in advance to your active participation in this presentation. Over the past several decades, researchers in various medical disciplines have been demonstrating a growing interest in understanding stimulant abuse and dependence. My name is Dr. Sonia Fulgham, and in this presentation, I will be talking about stimulant abuse and dependence with the focus of progression, identification, supportive data for use of medication in treating this, and potential usefulness of combined integrated treatment approaches. Let us begin by understanding stimulants and how they function. First, stimulants are substances that act on the central nervous system to increase energy, attention, and alertness with both positive mood properties and arousal attitude. Second, the mechanism of action generally entails activating natural stimulating pathways within the brain. Particularly, this involves the enhancement of the function of dopamine, adrenaline, and noradrenaline. Third, pharmacological stimulants have the capacity to increase stress monoamines synapse levels, thereby facilitating their release, decreasing their rates of reuptake by the brain cells, and increasing their capacity to stimulate the receptors. Fourth, there are four most common routes for the administration of stimulants, each with different pathways into the central nervous system. These include oral consumption, which is essentially swallowing, intranasal consumption or snorting, inhaling into the lungs mainly by smoking, and intravenous administration through hypodermic syringes. Stimulants use may have both short-term and long-term effects. The short-term effects may include wakefulness, euphoria, increased concentration, decreased appetite, nervousness, energy spikes, elevated blood pressure and pulse, as well as talkativeness. The extended use of stimulants could result in various long-term effects, which may include stimulant withdrawal problems such as sleepiness and severe fatigue, depressive mood with suicidal thoughts, and occasional spikes in appetite. Psychiatric complications like anxiety and mood changes tend to commonly manifest in individuals who have chronic stimulant use. Stimulant use and abuse has also been linked to neurological complications such as cognitive impairment and neurodegenerative disorders like Parkinson's disease. Other possible medical complications include dental problems such as severe tooth decay and cracked teeth, allergic reactions, and heart infections from injections of substances like methamphetamines, kidney and liver damage, and respiratory complications such as lung and pneumonia. So, you ask, what are the progression stages of stimulant abuse? Stimulant abuse patterns tend to follow two major progression stages, with each stage having different phases. The first stage is intoxication, which has the following three major phases. The initiation single dose phase is usually the early use of one dose of stimulant. Oftentimes, this results in energy spikes and euphoria, which match stimulant plasma levels closely. The consolidation dose frequency escalation phase is normally where the user tends to increase both the frequency and dosage of stimulant administration with the intentions to recapture the most intense and original rush sensation. And at this stage, the user might also change the mode of administration to get a speedier response. In the maintenance phase, with binging, frequent usage and high dosage patterns often result in compulsive binging over some hours to days. Such binging only stops when the user either runs out of the stimulant supply or suffers total exhaustion. The second stage combines the crash and withdrawal syndrome phase. The first phase of the crash and withdrawal syndrome stage is the early crash phase. The binge phase of the intoxication stage often ends with a crash that is characterized by various successive phases. For instance, anxiety, agitation, and dysphoria start shortly after ceasing to use the stimulant. This is then followed by an intense craving for the stimulant, which results in recidivism. The user might present with an iterative binging cycle that features an intervening crash in a period lasting for months. The middle crash phase is normally characterized by a period of anhedonia with reduced physical and mental energy, elevated depression, and fatigue. The drug craving might be replaced by an insomniac period with desire to sleep. The user might begin using such substances like opioids, benzodiazepines, or alcohol to prolong and induce sleep. The middle crash phase often ends with a protracted sleep period, typically for 24 to 36 hours. During this period, any attempt for therapy or other interventions is not appropriate. The late crash phase is the period of hyposomnolence, followed by the awakening of intense hunger. Protracted withdrawal is the last phase of the crash and withdrawal syndrome. After the crash phase or subsequent to earlier withdrawal, users may experience symptoms that are contrary to the stimulant intoxication symptoms. These include physical physical energy, reduced interest in the surroundings, anhedonia, fatigue, and depression, all of which may arise in intensity over the 12 to 96 hours subsequent to the crash. The identification of stimulant abuse dependence requires an understanding of the relevant signs and symptoms, which may be behavioral, physical, cognitive, or psychosocial. However, the DSM 5 criteria provides that the diagnosis of stimulant use disorder requires the presence of at least two of the 11 criteria within 12 months. The 11 criteria are stimulant intake in larger amounts or over a longer period than intended, unsuccessful efforts or persistent desires to reduce or control stimulant use, spending significant amount of time in an attempt to get, use, or recover from the stimulant, strong desire, crave, or urges to use the stimulant, repeated usage of the stimulant that results in the inability to undertake major role obligations at home, work, or school, continued use in spite of recurrent or persistent interpersonal or social problems that are exacerbated by the stimulant, and the reduction or abandonment of important recreational, social, or occupations, which is traceable to the use of the stimulant. Recurrent use of the stimulant in situations that are physically hazardous, and one continues to use the stimulant in spite of recurrent or persistent problems that are either psychological or physical. The tolerance that is not caused by the use of stimulant medications such as drugs for narcolepsy or deficit disorder. And finally, withdrawals that is not related to prescribed stimulant medications. Evidence available currently provides support for the usage of prescription psychostimulants in the treatment of stimulant abuse or dependence. Here's a list of medications: methylphenidate and its more potent dextratory form, dextromethylphenidate, have demonstrated efficacy and approval to treat narcolepsy and ADHD in many countries. MPH has been tested in the treatment of moderate to severe methamphetamine or amphetamine dependence and cocaine dependence, with less efficacy in the later stage. Amphetamines, like tetroamphetamines, which are registered as prescription psychostimulants, have also been used in the treatment of stimulant abuse and dependence. Both modafinil and armodafinil are psychostimulant medications that have approval for the treatment of excessive sleepiness in sleep apnea and narcolepsy and shift work disorder patients. Studies have shown that MOD is effective in treating cocaine or amphetamine use disorders. Apart from prescribed psychostimulants, some antidepressants and other medications have been found to be promising in the treatment of stimulant abuse dependence. They include bupiron, mirtazapine, topiramate, naltrexone, disulfiram, and N-isotocine or NAC. So at times, combining both psychotherapeutic and pharmacotherapeutic interventions or combining multiple medications in the treatment of stimulant abuse and dependence have proven useful and superior over choosing one over the other. Here are some benefits. An instance where therapy modalities like contingency management and cognitive behavioral therapy are not as effective, combining them with pharmacological interventions could enhance treatment efficacy. Normally, the treatment outcome of the psychotherapeutic interventions take time to manifest. Integrating pharmacotherapeutic interventions could speed up the process of the desired treatment outcomes. The application of integrated treatment approaches also provide more room for the prioritization of treatment goals that are tailored to suit the individual while ensuing coordinated efforts to improve both substance abuse dependence and psychiatric system. Combining or integrating treatment approaches could also help to overcome some of the shortcomings of one approach with the strength of the other. For example, psychotherapeutic treatment approaches for stimulant abuse or dependence have significant evidence backing, while pharmacological approaches do not. In fact, no medication is approved by the FDA for treating stimulant abuse or dependence. Therefore, combining pharmacotherapeutic and psychotherapeutic treatment approaches provides grounds for applying proven approaches and enhancing the chance of recovery. So, the following are the key takeaway points from this presentation. Stimulants act on the central nervous system to increase brain activation, causing an increase in energy, attention, and alertness, with both positive mood properties and arousal attitude. The effect of stimulant use are both short term, like euphoria, and long term, like psychiatric and neurological complications. Intoxication and crash withdrawal syndromes are the two principal stages through which stimulant abuse or dependence progresses. Each of these two principal stages have different phases, as presented earlier on. To identify substance abuse or dependence, the user must satisfy the DSM 5 criteria of exhibiting at least two of the 11 criteria within the past 12 months. And although the FDA has yet to approve any medication for treatment of substance abuse or dependence, prescribed psychostimulants, some antidepressants, and other medications have shown the potential to yield positive treatment outcomes. And finally, the use of combined or integrated treatment approaches for stimulant abuse or dependence have more potential to yield superior treatment outcomes and efficacy properly more than the use of one approach only. Thank you very much for your audience, and I'd be happy to hear your thoughts, comments, and questions at this juncture. Peace and light, and have an amazing day on purpose.